And I see, Dr. Walton, that you've joined us. How are you today?
I'm good. How are you?
Great. So, Dr. Walton, I want to start off, first of all, by thanking you for joining us on the show today. Also want to compliment you on your collection of plates in the background on your wall. That
Thank
those
you.
look fantastic.
Thanks.
Um, so, I want to start off by talking about your past experience. So,
Yeah.
this is not your first time with a big disease epidemic. Can you talk a little bit about your history?
Yeah, so I've been practicing medicine for about 20 years, and the trajectory of my career has really been both focused domestically. I went to medical school and practiced medicine here in Boston, where I'm sitting. Many people remember after 2010, there was a cholera outbreak in Haiti. And so we were working there at the time, the nonprofit that I was working with called Partners in Health. And in fact, we were actually trying to build a large hospital post earthquake to respond to the needs. And cholera actually broke out about a mile from where we were building the hospital. And so it was incredibly important that we stop the construction and really start focusing on those cholera patients. And, thankfully, cholera has a little bit dwindled in terms of the numbers affected in Haiti. But for a few months, I was very much redirected to treating cholera on the front lines there. And then in late 2014, as we all know, the Ebola epidemic was really affecting and ravaging West Africa. And so I took a leave of absence from the job that I was in at the time and went to Sierra Leone for about 6 months as a frontline clinician treating patients afflicted with Ebola.
And then right now, you're also working in Boston and dealing with COVID-19 patients right now. Can you talk a little bit about that experience and what you've seen over the past couple of weeks?
Yeah, absolutely. I mean, I think as most of us who are watching this are all sort of dealing in our own way with COVID, and it's been sort of on our minds. You can't look at the news without seeing about 1,000 articles about it. And so, my experience has really been from the very beginning. I work at a Harvard teaching hospital called Brigham and Women's, and we set up our COVID unit. Or unit is sort of where we take care of the COVID patients that are both COVID positive, but also we're ruling out for COVID or really testing to see if they have COVID because they have symptoms that could be consistent with COVID. And so in the very beginning, when we set it up, I think we were a little bit ahead of the curve because we didn't have that many patients. As many people know, who at least in the Boston area, Boston was unfortunately seeded with COVID, at least conspicuously, with a conference at Biogen. And there's a few
Mhm.
attendees from the Biogen conference who were from Europe, who were in contact with local Biogen employees, and that sort of went out from there. I'm sure there was community transmission before then, we just didn't detect. And so the first weekend that we had our COVID unit, we only saw a few patients that were COVID positive. But over the
Mhm.
last 3.5 weeks, that has increased dramatically, where we have, I think at last count, about 50 or 60 patients that are positive. And we're not quite New York in terms of the numbers that we're seeing, I think for a variety of reasons. One, we're still a very international city, but our population density just isn't what New York's is. But I think we're still on the very much on the inflection point heading up in terms of our numbers. And I know that both the mayor of Boston and the governor of Massachusetts is very keen to sort of continue the social distancing. But in terms of hospitalization, we're continuing to see more and more cases every day.
Mhm. So, based on your experience, both in dealing with epidemics in, more impoverished regions or emerging economies, and then also, what you've seen with COVID in Boston so far, what do you think are the biggest concerns as this coronavirus, spreads to other regions on the map, maybe places that don't have as strong a healthcare infrastructure or where it might be more
Mm.
difficult for patients to see a doctor.
Yeah, I think it's really important to understand that, this disease, although it, is a novel disease in humans, diseases in general and illness in general, certainly, as we know, affects those who are marginalized more than others. And so we see that playing out here in the United States, and we also see it playing out outside our borders. And I think it's a little bit of a new experience for me dealing with epidemic disease here in Boston, and new to actually have shortages. So at the Brigham and Women's, and they're very open about it, the hospital that I work at here in Boston, we do have shortages of PPE. We are conserving our PPE as much as we can because we're worried that, like many other hospitals, we're not sure when that shipment is going to come of our masks and of our eye protection and of our gowns. But thankfully, we do have those. Again, we're short, but we do have them. When I think about other places that I've worked in, many other places in the world, there are billions of people who live in countries with very fragile health systems. We've been able to, I know our response has been mixed in terms of sort of the response from both state and federal governments. But when we think about sort of our response, it is still pretty robust, although some would like it to be a bit stronger. Other countries don't have even the ability to mount a response like we have, as sort of fraught as it might have been. And so places that don't have access to medical professionals, places that don't have access to hospitals or healthcare centers. And in fact, I've been talking to many of my colleagues around the world who are asking me questions like, well, I understand this, but I have no way to test it, right? We're short on testing more tests. Many of my colleagues don't have an ability to test for COVID, despite the fact that COVID is continuing to increase in numbers in those settings. Many of my colleagues don't have PPE. What do we do, they say, when we actually don't have goggles, we don't have face masks, and we don't have gowns? What are our options? And how do we prevent COVID patients who we might be seeing in the hospital from infecting a woman who's there to deliver a baby who doesn't have COVID, or a gentleman who had an accident who broke his leg who also doesn't have COVID? So these are critical questions that my colleagues and so many others are really grappling with around the world. There are successful strategies to deal with that, even in low resource settings, but it's still, people are still figuring out how to really grapple with this disease in the setting of such both mounting cases and lack of resources.
So, you mentioned that there are some strategies that places with fewer resources might be able to employ. From talking to your colleagues and just your own experience, so what are some of those strategies that are helpful and might work?
So the strategies that that we're recommending and that I talked to with my colleagues are not different fundamentally from the strategies we're using here, whether it's here in Boston or elsewhere. I was just on the phone this morning with colleagues in Uganda who are preparing for increasing numbers of patients by thinking about sort of working on infrastructure and their infection prevention protocols. So fundamentally, like here in Boston, everyone should be screened, right? If you have testing, please test everybody, right? And if you don't have that many tests, test those who are presenting to you with symptoms. In order to prevent people that might have COVID from contaminating others or spreading the disease to others who don't have COVID, you really have to screen at the entrance of the hospital. We're doing that here in our Harvard teaching hospitals and in other hospitals in Boston and other places around the world. It's just a fundamental principle of trying to prevent those infections from spreading. Secondly is, again, as we all hear in the media, test. Really want to test everyone. And thirdly, we really need to figure out, particularly in resource poor settings, how to get the supportive care that we have here. I mean, I think it's important to understand when we're sick, this is a respiratory illness, right? A lower respiratory tract illness. And that means that people often have trouble breathing. And that's partially due to the immune reaction that happens in the lungs. And here in the US, you get hospitalized, you get put into a hospital room, someone turns up the dial on the oxygen that's connected to the wall, you get your nasal prongs, and there you go. You're off and running. In places like Uganda, again, we were talking about oxygen access today. So many places don't even have access to oxygen. So when you think about sort of the mortality numbers of places like Italy and China and even the US, and you see mortality of, say, 1% to 3%, that's with resources. So imagine, if you will, a scenario where you might have a place to hospitalize patients, but not private rooms like we have here, but wards, so 10 to 15 patients in a single room, large room, but then no ability to actually give them the supportive care that they need because you don't have those resources. it goes without saying that more people are going to die and more people are going to do worse. And so it's, one of the things that we keep thinking about is how do we help our brothers and sisters who are not, are sort of in these scenarios, think about increasing their oxygen ability, their ability to deliver oxygen, increasing their ability to sort of potentially move these patients to a separate part of the hospital or a campus in and of itself to prevent infection. How do we think about really beefing up the supportive care that they're able to receive?
Got it. Thank you. And for those of you just joining us, we were talking with Dr. David Walton, who's the CEO of Build Health International, and talking about the response to the COVID-19 pandemic in impoverished regions and emerging companies. We're going to start taking some questions
Sure.
from the audience that our social team has been highlighting to me. I think one of those is just a real quick basic question, which is, you mentioned the acronym PPE. Can you, for those who aren't familiar, can you tell us what PPE is? And then, there's a shortage of it, both here and abroad. Are there things that, while people are at home and they're social distancing, are there ways that we can help get doctors, both here and abroad, that equipment that they need?
Sure. No, great questions. I apologize. Medicine is full of acronyms, and we often slip up with way too many acronyms. So PPE stands for personal protective equipment, as you mentioned. And the degree of PPE depends on the type of transmission of the disease you're talking about. So folks who may be watching this may have seen the PPE that we were wearing in West Africa in Ebola. Head to toe, Tyvek suit, double gloves, mask, goggles, 2 masks. And it was very intense. It took us about 20 minutes to put that on and longer to sort of doff, as the fancy word for taking that equipment off. It is important to understand PPE needs to be matched to the transmission dynamics of the illness or of the virus in this case. So conventional wisdom and sort of our scientific wisdom to date, although there's still a little bit of controversy, is that this is spread via droplets. What does that mean? It means if I'm speaking to you or coughing or sneezing and you're within 3 to 6 feet of me, I have the potential to spread the virus to you, right? That's very different and important to understand, different from airborne transmission. Airborne transmission is things like tuberculosis and measles, where I could be in a room, I'm infected, I breathe, I sneeze, whatever, those little droplets are small enough where they hang in the air, and then I walk out of the room, you walk in the room, breathe that air, you could become infected. So way more transmissible. And that's reflected in things like when you see how infectious measles is, one person on average infects 17 other people, versus COVID, one person infects around 2 to 3 people. So again, that our PPE needs to be matched to transmission dynamics. In this case, what we call droplet precautions. What does that mean? It means eye protection, because if you get droplets in the eye, that's actually a portal of entry for infection. Obviously, covering your mouth with a mask, so goggles, mask, because again, oral mucosa. And then ultimately something covering your front, typically gowns that we're using in the hospital, to prevent any sort of droplets from landing on your clothes. And then obviously gloves because we should be using gloves all the time. So that is sort of the PPE that we're using. There is a different approach to the PPE. Italy and China and other places in Asia use the sort of Ebola style PPE. Is it overkill? Is it not? They're being extra safe with their healthcare providers. We're doing what's recommended by the CDC. I think in terms of how you don't have enough PPE, the CDC, or the Center for Disease Control, has actually released recommendations around how do you MacGyver, as it were, or maybe I may be dating myself. How can you protect yourself if you don't have all those things? They've gone so far as to say if you really don't have any masks whatsoever, use a scarf. They're not saying it's going to prevent infection, but they're saying this is going to at least be somewhat preventative, understanding the transmission dynamics. Alex, you're wearing eyeglasses. Those aren't recommended primarily because droplets can get in on the side. But if eyeglasses is all you have, again, perfect is the enemy of the good, but we really, really want to strive to protect our providers, our healthcare providers, because again, in Italy and other places, when they get sick, then there's really many fewer people to be able to, deliver care.
And then how can kind of the global community do more to combat this pandemic, particularly, as we're learning more about it in a wealthier, more research-rich country like the United States, what can we do then to carry our experience
Yeah.
to other countries with more fragile systems?
I think, it's a great question, and it also speaks to the PPE question. I mean, there's global PPE shortages, right? So,
Hmm.
this is when I was a clinician with cholera, fighting cholera or fighting Ebola, we never had shortages of PPE, right? But now the entire world needs PPE, and the manufacturers can't keep up. So I think continuing to advocate for PPE, I think there's really, really great ways that entrepreneurs and others in the private sector are figuring out novel approaches to PPE that may not have to be manufactured by 3M or what have you. And I think that's important. So people who may have connections to that world continue to ideate and sort of innovate on that score.
Hmm.
And then secondly, really, I think it's really, really critical to understand this is a global disease. Dr. Fauci, who many people have sort of heard speak sort of with President Trump, who's one of the leaders sort of in our government fighting this, he mentioned that even if we have a lull here, it doesn't mean that there won't be a resurgence. At some
Hmm.
point, we're going to have to open up our economy again. We're going to have to get back to work. I'm not the person to know when that is. That's above my pay grade. But at some point, we're going to need to do that. But that means that people from all over the world are going to be coming in and out of this country again. And unless we think globally, we need to think locally, absolutely. And we need to sort of help our neighbors and friends and everyone who's right next to us. But unless we think globally and act globally, we're never going to sort of be free of this disease, because we are a globalized economy and a globalized world. And pathogens don't sort of understand or adhere to sort of the borders that we have, the political borders that we have between countries as humans. And so I would encourage everyone in this audience to really be critically thinking about how they can help, how they can, I had friends who have connections to places with PPE, and they were able to get me PPE that we could then sort of divert to, my colleagues at the hospital, people who are, there may be engineers thinking about how to create a low cost ventilator or maybe connected. Again, we're short many tens of thousands of ventilators, New York and elsewhere, and we're going to need them, and we're going to need them soon. So there's many, many ways for people to plug in. But I also think that most importantly, as humans and individuals who are at risk of this disease, protect yourselves, protect your loved ones. Really, I know social distancing is hard, and people are out of work, and our unemployment is through the roof. But it's so critically important that we can continue to wash our hands and do all the things. I have a ton of hope. I know that we're going to get through this, and I know that we can band together as both a country, a society, and humanity to sort of move past this. But it's going to take a lot of work by everyone, each individual person, in order to get through this.
A question here that has been a common one from the audience is
Mm,
there seems to be a real different response between countries in
mm,
how well or how poorly they've kind of initially
yeah,
responded to the pandemic, where, kind of just like Taiwan, we're
yeah.
testing right away. And then even developing economies, like I know Nigeria was able to act very quickly, and they started
Hmm.
imposing social distancing, I think even before their first case was
Hmm.
confirmed. What
Yeah.
do you think informs those decisions? Like, what makes some countries more inclined to act quickly versus not? Is it just experience with that epidemic? Is it just size of the country? Just based on your experience, what do you think that difference comes from?
I mean, I think a couple things, right? This sort of came to light end of December, early January. We're now our fourth month in. And I
Mm,
think, this began in China, spread through Europe mainly initially, and sort of some of the countries in Asia, and then the US. A lot of the countries who are just beginning to have cases have 3.5 months of watching
mhm,
the world really grapple intensely with this, with the successes in China and South Korea, and then really the struggles of Italy. And so ultimately, they're able to be a little bit further downstream and understand the necessary things that they need to do in order to protect themselves and their citizens. I think it's also a reflection of, if you are in a country with a fragile health system and don't have the ability to respond from a public health standpoint, that like we are, or like China had, or like South Korea had, you have to act quickly. Because if you, I think it's important to highlight, the first case of COVID was diagnosed in the US, I think in the beginning of January, or early first 2 weeks of January, 1 day later in South Korea, or vice versa. And South Korea acted quickly and decisively while their numbers were low. We're able to drive those numbers down. We're now in a situation in the US where we're really going to struggle. And, President Trump and others have talked about the 100,000 to 200,000 potential deaths, let alone hundreds of thousands of cases that we're going to have in this country. Hindsight is 2020, but I think when you look at our response in the US versus South Korea, they were really able to act quickly and decisively. When you look at countries who are acting now, they want the South Korea experience. They don't want the US experience or the Italy experience. And they're getting guidance from the WHO as well, who is very, very adamant that countries really act aggressively, and not defensively, but offensively, with active case finding, with as much testing as possible, and really driving the numbers down so that you don't get to a place where we are today, which is not a place where we ever envisioned we would be.
Another question from our audience, based on your experience with infectious disease, an interesting thing about COVID is that there's a really wide range of impacts. So you can be, there's a certain percentage that has no symptoms and yet, is contagious, carrying the virus, all the way to, a really significant portion of people who have to be hospitalized, and then even more severe cases requiring intubation ventilation. Is that a common thing, or is that something that we're also kind of learning how to deal with?
It's common. So it is common. And so I'll give you it's common insofar as a disease, choose a disease, has an entire spectrum of how it affects people, right? And even the flu. Some people get the flu and they have sort of mild symptoms. Some people get the flu, and in fact, like people with severe COVID, they have to be on with a tube down their throat or intubated and on a respirator. And many, many people die of the flu every year, whereas other people, even who aren't vaccinated, get mild cases. So there's always a spectrum of disease. In medical school, we learn sort of how a disease typically presents, but the challenge of medicine and the art of medicine is to understand that it can present in any which way, and you really have to think broadly and creatively about that. And so when you think about COVID, it's not anything that we don't understand in terms of the spectrum of illness. I think two things are at play here that make it a little bit worse than what we've seen before. One is no human has immunity to this at all on the planet. And so that's coming to play in a big deal, and which is part of the reason why everyone is sort of really getting affected quite rapidly, in addition to the transmission dynamics. I think secondly, it's still not well understood why children aren't really affected, but older people are doing incredibly poorly. Now, there are some theories around that in terms of older folks with what we call comorbidities, or sort of illnesses in addition to COVID. So hypertension, diabetes, things like that. When one has diabetes, hypertension, heart disease, et cetera, there's thought to be a pro-inflammatory state, so a lot of inflammation in the body. This is a theory now in terms of COVID. And the people who do poorly with COVID, it's really the immune reaction, right? Your lungs just get incredibly bogged down with fluid inside the lungs, so much so sometimes you can develop so much fluid that you can't breathe, have to be on a ventilator, and some people don't make it. And the question that medicine has, it still hasn't been teased out, is that because older people who aren't doing as well they're already revved up from an inflammatory point of view, and this just adds fuel to the fire. It's still unclear, it's still unknown, but that's an open question. And so, to the extent that there's a spectrum of disease, this is not unlike any others, but we're learning about this for the first time and understanding the morbidity and mortality And there's still much to be discovered around why COVID acts the way it does in the segments of population that it does.
Got it. Well, I think we have about time for one more question before we have to wrap this up. So another one from the audience is, as countries are reacting to this at different times, what does the exit strategy look like? Is it just one day everyone's like, all right, go back to normal, or are we going to be, or is it more like we ease restrictions kind of slowly over time? What's kind of the state of play in that sense?
This is a great question, and I think so many people are talking about it. I think it really is unclear. Again, I will take a page out of Dr. Fauci's often cited term when he says it's the virus that determines the timeline, not us. I think in this country, if I look forward, I don't think we can go from full social distancing to, all right, let's go to the movies and have a movie theater packed with people. I don't think it's binary like that. I think we're going to need to figure out how to maintain a degree of social distancing because the virus isn't going away, and continue on opening up our stores, opening up our restaurants. And I know that governments and states are already planning for the sort of post sort of social distancing, or at least mandated social distancing world, where we still need to really be critical in terms of really be thoughtful around how we're protecting ourselves and others from this disease. And I also think I would urge everyone to just be cautious that we may see a lull as the summer months come. Transmission dynamics aren't fully understood, but there may be less transmission in warmer climates. And I happen to live in Boston, and I'm really thankful in the coming months when it'll get warmer. But if we do see a lull in cases, that does not mean it's gone. And it might, like the 1918 flu that many people are now rereading about, we may have another sort of upward slope as winter descends upon us in 2020. So I don't think this is going to go away anytime soon. And I actually don't think that sort of what we're doing in terms of social distancing and how we're adapting to this new reality is going to be changing anytime soon either. So I think it's a marathon, not a sprint. And we're going to all have to adapt to a new world that happens to be sort of really through the lens of COVID.
Great. Well, thank you very much for your time, Dr. Walton. Very much appreciate you coming on and talking to our audience.